I'll be doing my presentation on evaluation of squint, which is basically a sensory evaluation. I am Dr. Saifuddin Alam, PG Ophthalmology second year. So my specific learning objectives will be sensory adaptation, the mature and immature visual system, the normal retinal correspondence, abnormal retinal correspondence, monofixation syndrome, interpretation of diplopia charting, and sensory evaluation. So why sensory evaluation should be done before motor evaluation? Because binocular sensory testing is performed before tests that require occluding one eye, such as visual acuity testing and the cover uncover test. Covering one eye will dissociate the eyes and disrupt fusion in a patient. That's why first sensory evaluation should be done, followed by motor evaluation to break the fusion. Corresponding points. So corresponding points means in the normal retina, the two images will lie on the same points in one eye and in the other eye. As for example, we'll see that the red box which is falling on the AL in the left eye and AR in the right eye. The triangle which is following on BL in the left eye and BR in the right eye. So the AL and AR are the corresponding points for the red, and the BL and the BR are the corresponding points for a triangle. For example, a receptor located 5 degree temporal to the fovea in one eye corresponds to a receptor located 5 degree nasal to the fovea in the other eye. So we have to know that the two images fall on the corresponding points in either of the retina. Horopter. Horopter is actually a horizon of vision where the stimulus appears single due to retinal points. So if we see the line here, this is a line where we are seeing the images. So the images will fall on the corresponding points of each retina. Examples, if we see for the left eye, the images is falling accordingly like A, B, C, D, E, F, G, as it is on the space, and same is falling on the right eye as A, B, C, D, E, F, G, and the image will intersect at the nodal point. So there is a Wet-Muller horopter. Actually, the full name of horopter will be a Wet-Muller horopter. It's a circle forming by the fixation points and the pupil. The empirical or the horizontal horopter curve has a larger radius than compared to the normal wet horopter curve. The Panam's fusion area. The Panam's fusion area, example, this area we are seeing in the space, this entire area. The horopter is at the center, passing through the Panam's area. If any area above it is seeing, that area will be an area of uncrossed disparity, and if we are seeing any area below it, that will be the area of cross disparity, and the entire area is known as the Panam's zone of fusion. So the Panam's fixation space refers to the area where extends double vision does not occur. So if we are seeing anything in between this, there will be no double vision or diplopia. It's smallest at the fixation point and expands towards the periphery. So if it has a fixation point here, it is smallest here, and as we go towards the periphery, it will become smaller and smaller. The size of the Panam's area varies based on the stimulus, such as it also depends on the size of the object, the sharpness of the object, and the speed at which we are seeing the object. The sensory adaptation, it mainly depends that the visual stimulus, at what age it's developed. Normally it is considered as 6 years of age, 4 to 6 years of age, according to Von Nuden and Kenneth Wright. It also depends on when the sensory visual stimulus has occurred, abnormal sensory visual stimulus has occurred, severity of the abnormal stimulation, and the types of binocular disruption. It has 2 sections, depends whether the visual pathway is mature or whether the visual pathway is not mature. Taking into consideration that the visual pathway is mature, we get only 2 conditions, that is either a diplopia or a confusion. To simplify, if we are seeing an object and the deviated eye is seeing, one eye is seeing an object that is a vase or a balloon, and the other eye is seeing a light. Diplopia means both eyes will see only the balloon, but confusion means one eye will see the balloon and the other eye will see the other object. That is the main difference between the diplopia and the confusion. Diplopia is of two types, cross diplopia or uncrossed diplopia. Mainly if there is a iso deviation, means eyes is turned inwards or towards the nose, we get uncrossed diplopia. And if there is a exo, then in that condition we get a cross diplopia. A normal common mnemonic for it is XT. X means cross. So if XT means exotropia, we get a cross diplopia. And there's a condition known as anisoconia. Anisoconia means both eyes sees different size of the object. That can be controlled properly if the disparity is 7%. But if the disparity is more than 10%, then in that condition we get to see diplopia. As I have already told, what is confusion? If one eye is seeing an object ball and the other eye is seeing a star, then one eye will perceive a star and a ball, and the image which will be seen finally will be star on the ball. But in diplopia there will be only one image that will be seen by both the retina, but one image will be blurred as compared to the other. As we can see here, the right image is blurred as compared to the left image. So, if the visual pathway is immature, that is the disruption has occurred before 6 years of age, it depends on 4 factors: the size of the strabismus, whether it is intermittent or constant, the age of onset of strabismus, and the age where the strabismus has been corrected. In case of strabismus and one eye having blurred vision, the brain usually suppresses the unclear image to avoid confusion. So confusion is a very rare condition. We usually don't get to see confusion, but we get to see diplopia. And if the visual pathway is immature, the blurred image will be suppressed by the brain, and we get to see only one image. Means the image from that eye will be suppressed, and we will get to see only one image, which will be from the normal eye or the non-deviated eye. Coming to monofixation syndrome. In young adults or infants with slight misalignment, that the first condition for monofixation syndrome is the deviation should be less than 10 prism diopters or mild to moderate blurriness in both eyes. The brain suppresses the central vision of the blurred eye or the deviated eye. Example, if there is a deviation in two eyes, but that deviation should be less than 10 prism diopters, and in that condition the brain suppresses the image, means the central image from the deviated eye. This condition is called as the monofixation syndrome, which was first described by Parkes. Suppression happens at a central 4 degree. We should remember that the suppression is happening at the center, but the peripheral fusion is normal. Why? Because in the central retina will have a small perceptive fields but high resolution. So any disparity, if it is at the center, will be detected by the brain, but disparity at the periphery is not detected by the brain. So the peripheral fusion in this patient is normal, but if the image is falling at the center, there will be a suppression at 4 degree center. So there is the condition, the peripheral retina. In this condition, there is a small angle esotropia in the right eye, that is 6 degree, which follows, like as I have mentioned, the esotropia or the deviation should be less than 10 prism diopter. So there is a central suppressive scotoma, and the brain fuses image of this eye, and the patient get to see a single image. Or in a patient having anisometropic amblyopia, in which one eye is normal and the other eye is having central suppressive scotoma, in that condition also the brain sees only one single image and there is no diplopia. So monofixation syndrome is just a method by the brain to avoid diplopia. If a patient with monofixation syndrome often have both motor fusion and a significant underlying phoria with a small tropia, this condition has a special name known as the phoria-tropia syndrome. The stereo acuity in these people is usually 3000 to 7 seconds of an arc, and central suppressive scotoma measures between 2 degree to 5 degree. The normal stereo acuity is between 40 seconds to 70 seconds of an arc. Coming to second point is abnormal retinal correspondence. Before that, we will talk about what is a normal retinal correspondence. As I have explained above in the horopter and the Panam's area, that the normal retinal correspondence links that in both fovea, the image is falling on the same foveal points. But a normal retinal correspondence is a condition in which if in the normal light, the image is falling on the fovea, but in the abnormal light, the image is not falling on the fovea, rather than a new point which is called the pseudofovea. But the brain is fusing the image from the fovea and the pseudofovea, and the patient get to see only one single image. So this is also a condition in which the brain suppresses the fovea image, but parafovea is there and patient get to see one image to avoid diplopia. In this, the deviation can be more than 10 degree as compared to the previous monofixation syndrome, but it should lie between 15 degree and 30 degree prism diopters. ARC helps eliminate double vision by recognizing the visual cortex to create a pseudofovea. There's a true fovea obviously there in that image, but a false fovea is created in the deviated eye called as the pseudofovea, and it corresponds to the true fovea of the non-deviated eye. So patient doesn't see diplopia. But if we are planning to correct a patient who is having ARC, we have to counsel the patient that after surgery there might be slight diplopia, but the diplopia here is called paradoxical. Why? Because we have known that patient with EZO will have uncrossed diplopia, but in this condition the image is not falling on the fovea or in the pseudofovea, but is falling somewhere between it when a 15 degree prism diopter is placed or when the eye is corrected after surgery. So the patient get a cross diplopia in case of EZO deviation. That's why hence termed as paradoxical diplopia. So there are two types of abnormal retinal correspondence. The first comes is a harmonious, where the pseudofovea compensates for the strabismus deviation. There are three things to know here: the objective angle, the subjective angle, and the angle of anomaly. The objective angle, as seen by this diagram, is the distance where the image is formed from the true fovea. The angle of anomaly is the distance between the fovea and the pseudofovea, and subjective angle is the distance between the image and the pseudofovea. So in case of harmonious retinal correspondence, the subjective angle is equal to the objective angle. So there is no angle of anomaly and the image falls directly on the pseudofovea. But in case of unharmonious ARC, the subjective angle and the objective angle are not equal. So there is a discrepancy and the patient get to see diplopia. Large regional suppression. It depends on when the stimulation for strabismus or when a cataract is there in that eye. In young adults more than 6 years of age, the image from that eye is blurred. For example, here the image from the right eye is blurred. So the patient get to see image only from the left eye because of the suppression. This is a Wert-4 dot test. Wert-4 dot test is a test which I will be talking about. It's a type of sensory evaluation. If a Wert-4 dot test is performed with large regional suppression of the right eye, the two dots within the suppression photoma will be blurred, so, and the patient receives images only from the left eye. Now coming to the sensory test. The first test I will be talking about is the diplopia chart. The use of diplopia chart provides a record of separation of images in all positions of the gaze, starting from the central position to the primary position to the secondary position to the tertiary positions. The separation between two images indicate the subjective deviation. It helps to understand the type of squint and it helps to diagnose the nerve palsies. Prerequisite for the test is the red-green glasses, in which the red glass should be in front of the right eye and green glass in front of the left eye. There should be illuminated target with a slit. Here we are using a retinoscope. Red and green pencils to do the interpretation of the diplopia charting, a dark room and a patient with good comprehension and it is a subjective test. To procedure, with head erect, wear red glass in front of the right eye and green in front of the left eye. The light source should be kept 50 cm away from the patient. The patient is asked to indicate relative position of the two images either with his finger or with the color pencil. If the patient is educated enough to draw on itself, we give the color pencil to the patient and tell them to draw the image, how they see, how are they oriented, what is the difference between the images in all the cardinal positions. So the separation, patient is questioned three things: the separation, the orientation and the tilt of the image seen. So this is the procedure. First we will do in the primary position, then the midline position, which is the superior, inferior, followed by the dextro elevation, dextro depression, levo elevation, levo depression in the all 9 positions of gazes. So here are some diplopia charting which I will be doing. How to identify the diplopia charting? First, we should find the maximum separation of the images. The outermost images indicates affected eye. We should note the yoke muscle in that gaze. The horizontal separation with uncrossed image will have ESO deviation, as I have talked about previously, that uncrossed image means ESO, crossed means exo. So horizontal separation with crossed image have an exo deviation. If there is a vertical separation with crossed image, then definitely a vertical recti muscle is involved. And if there is a vertical separation with uncrossed image, an oblique muscle is involved. So coming to the diplopia chart interpretation, first we see that this is the right side, this is the left side. In the right side, we are giving the red glasses. So the image of the right is falling on the right, the left is falling on the left. So this is an uncrossed diplopia. Second, we have to find out is which position is having a maximum separation of image. So as we can see, in case of dextro version, we can see that that position the difference of the image is maximum. So if in case of dextro version, we will see that the right eye it's medial rectus and the left eye is lateral rectus. But in this position, we can see the left eye is not affected. So definitely it's the right muscle which is affected. So the answer will be light lateral rectus palsy. Because in dextro deviation, the lateral rectus comes into action and the left side medial rectus comes into action. The left side medial rectus is not affected since it is in its position in all the 9 gazes, but the right muscle has been changing its position. So it is definitely the right lateral rectus palsy. Coming on to the next interpretation, in this side, this is the right eye, this is the left eye. But in this condition, in the primary position, we see that in the right side, we are getting the green which we have placed in the left eye. So this is a case of cross diplopia. Now we will see which is having the maximum deviation. So this image is having a maximum deviation, levo version. So in levo version, the left eye lateral rectus and the right eye medial rectus come into position. But here the left images are in its position and there is no deviation, but the right side image is deviated. So the right medial rectus palsy. Coming on this image, the right we can see at the right and the left we can see at the left. So it is a case of cross diplopia. The image which is having a maximum separation, the position is this dextro elevation. So in dextro elevation, the right eye superior rectus and the left eye inferior oblique comes into action. As we can see, the right side muscle is in its position and the left eye muscle is only deviated. So it is left inferior oblique palsy. As we know that dextro elevation, the right eye superior rectus and the left eye inferior oblique come into action. Coming on to a last diplopia interpretation, right side, left side. The right eye image is falling on the right eye and the left image is falling on the left eye. So it is a case of uncrossed diplopia. The image which is having a maximum separation is the levo elevation. So in the levo elevation, the left eye superior rectus and the right eye inferior oblique come into action. But here we can see the right eye muscle is not affected since it is at its position in all the gazes, but the left eye muscle is affected. So it is a left eye superior rectus palsy. The advantage of this is very helpful in identifying bilateral palsies, especially the fourth nerve palsy. Can be used in bedridden patient where the head start is not possible. The disadvantage is it is a purely subjective test. The reliability is a question, reproducibility is a question, as the patient has to be very comprehensive how far is the image in all the positions and will have to tell you properly where the image is lying so that you can do the interpretation. And the follow-up is also a doubtful. Coming to the red filter test. Red filter test is a simple diplopia assessment in which a straight eye with normal retinal correspondence, imagine if there is no deviation and both eyes are straight and we shine a torch and put a red filter in front of any eye, we will get only one image, that is the pink image, which is seen by both the eyes. So Fourier presence may induce double vision. If we use a denser red filter, that will intensify the dissociation. If we dim the room light, then we'll eliminate all the peripheral fusion clues, and this test is more effective that time. It is helpful in identifying the normal retinal correspondence, abnormal retinal correspondence, and the suppression. So esotropia with NRC will cause uncrossed diplopia. Exotropia with NRC leads to cross diplopia. If we neutralize deviation with a prism, that will help in resolving the diplopia in cases of a normal retinal correspondence. Abnormal retinal correspondence typically see only one light due to pseudofovea, as we have seen in monofixation syndrome. Strabismus with separation results in perceiving a single light, that is a red light or a white light. If there is a suppression, the image from that eye will be suppressed by the brain, and we get to see only the image from the non-affected eye. And alternating fixation may lead to seeing two lights, indicating suppression rather than the diplopia. So in this condition, we see that the right eye is having esotropia, and we have put a red filter. This image is falling within the suppressive scotoma, that may be 4 degree or 6 degree. That's why image from the right eye is suppressed, and only the patient will see one image, that will be from the left eye. So patient sees only one white light. Vertical prism red filter test. It helps to differentiate ARC from NRC. In this, we use a red vertical prism, that is usually 15 prism diopter, base down. This is the base, this is the apex. So the base should be down over the deviated eye. As this eye, left eye is having esotropia, right eye is normal. So the prism is placed vertically down over the left eye. ARC patient see two vertically aligned lights due to pseudofovea. So here, if we keep a prism in the left eye, we shine a torch, the right eye is normal. So the right eye image will be perceived as a white light. But since the image in the left eye is falling on the pseudofovea, so that image also will be perceived by the patient, and it will come as a red light. But this in the left eye, the pseudofovea is more nasal to the true fovea. That's why when we perceive the image, we will see only a vertical deviation. But in this eye, in the left eye, the pseudofovea is more nasal to the fovea. That's why we get image from the left eye superiorly and the image from the right eye inferiorly. But there is only vertical deviation and no horizontal deviation. But if we see a patient who is having a left eye esotropia, and in this eye, the right eye is normal, the left eye, the image is not falling either on the fovea or on the pseudofovea. So we get to see both vertical deviation and horizontal deviation. But here, since the image is not falling on the pseudofovea, so it will be not aligned horizontally, but there will be both vertical and horizontal deviation. So the patient will receive light from the left eye more horizontally separated, and in the right eye it will be at the center. What 4 dot test? What 4 dot test implies red box, red or green glasses and a flashlight or a light box. In this, there is a what 4 dot test in which the board will have one red light, two green light, and one white light. And we give a red green glasses, means red glass in the right eye and green glasses in the left eye. And the patient is asked to see the image. So the normal fusion response will see 4 lights, 2 green and 2 red from each eye. Patient with strabismus and diplopia may see 5 lights, that is 3 green and 2 red. 3 green images will be in the left eye, and 2 red images will be on the right eye. So in case of what 4 dot test, in case of a monofixation syndrome, if we are doing what 4 dot test near, that is 1/3 of a meter, in that case the image will be falling on the peripheral retina. So the image won't be suppressed, and the patient will be seeing 4 images as a normal person. But in case of monofixation syndrome, we do what 4 dot test for distance. In that condition, the image falls in the right eye over the suppressive scotoma. So the images in the right eye will be suppressed, and the patient will be seeing image on the left eye as seen here. So this is a very dissociated test. If we dim the light, then the dissociation increases, and if we turn on the light, then there is more peripheral clues, and the test is not as much reliable as compared to distance. So if the distance from the patient of the light is 1/6 of a meter, it makes a what 4 dot angle of 12 degree. If it is 1/3 of a meter, it makes an angle of 6 degree. If it makes half of a meter, it makes an angle of 4 degree, and if it is 1 meter, it makes an angle of 2 degree. So coming to word for dot test interpretation, if the eyes is normal, the patient get to see word for dot test like this or like this, means the white provides clues from both eyes, so it can be seen as white or brown. If there is a left eye suppression, means 3 green images will be falling on the left eye, that will be suppressed. So patient sees only right eye image, that is the red. If the right eye suppression is there, so the images from the right eye suppressed, that is the 2 red dots, so the patient sees only 3 green dots. In case of uncrossed diplopia, the right image will be on the right, the left image will be on the right. So right is having red, left is having green. In case of cross diplopia, we see that the right image which was red has come to the other side. So it is a cross diplopia, and the green which was on left, it has come to the right side. In case of a left hyperdeviation, means left is above, so the image will be falling below. So the right eye image will be above and the left eye images will be below. In case of right hyperdeviation, the left eye image will be superior. So 3 green dots we are seeing superior and the left images we are seeing inferiorly. Bagolini glasses. Bagolini striated lenses consist of clear lenses with a linear scratch through the center, creating a streak of light on the retina when viewed in a bright light. The striations are made so that one eye it is at a 45-degree angle and the other eye is at a 135-degree angle. They provide a binocular view without dissociation. That's why it is one of the most reliable tests. And it helps to differentiate between NRC, ARC. So we'll do an interpretation. If the patient is orthophoric or having an NRC, there will be a normal cross. So the right eye image will be fall on the left eye. That's why the left eye images will be on the right eye and the right eye image will be on the left eye, and there will be a normal cross. But if there is a suppression of the left eye, there will be only view of the right eye image. If there is a monofixation syndrome, as we have learned that in monofixation syndrome of the left eye, there is a central scotoma. So the patient has a difficulty to see at the center. That's why there will be a discontinuity of the line in the left eye, but the right eye, the line will be straight. So at the center, there will be a breaking. If there is a exodeviation, in Bagolini, it forms a V pattern. Isodeviation, the Bagolini forms a V pattern, but if there is an exodeviation, the Bagolini forms an A pattern. Maddox rod test. Maddox rod test is to identify the horizontal, vertical and the torsional deviation. It consists of a stacked cylindrical high lenses given to a washboard appearance. Viewing the light through the Maddox rod produces a linear streak of light perpendicular to the cylindrical lips. As we have seen, the Maddox high cylinder has perpendicular to each other. So if we are testing in the right eye, we will put the Maddox rod vertically aligned, and if we are putting in the left eye, it should be horizontally aligned. So the interpretation is, if we put the Maddox rod in the left eye and the right eye is kept without a Maddox rod and the torch light is shined, we see a orthophoric image, means the torch image at the center with the vertically aligned images crossing over it. So in this condition, it is a orthophoric. If esotropia is there, the right eye will have a torchlight image in the right eye, the left eye will have a vertical image of the Maddox rod to the left side. So there will be a uncrossed diplopia. But if the patient is having exotropia, so the right eye will see the torch, which will be interpreted at the left side, and the left side, which will having a Maddox rod, will have a linear streak of light on the right side. Same as in case of hypertropia, the linear streak of light will be superior to the deviated eye, and in hypertropia, it will be inferior to the deviated eye. Synaptophore. The synaptophore or amblyoscope is a haploscopic device. Haploscopic means in this type of test we use both the eye, as in other tests we have been covering one eye and using other eye as a reference. Here both the eyes have been simultaneously tested. It provides a strong binocular vision disorders. So it consists of two tubes which are right angle to each other. There is a forehead rest, there is a chin head rest, and here all the vertical, horizontal and the torsional deviations can be controlled. So this is a horizontal deviation control, this is a vergence control, and this is a vertical deviation control. The IPD of this can be adjusted by the IPD adjuster. Each light can be used separately or together. So this instrument can be also used for a cover uncover test. And because the image is falling so near, if we have to perceive the image as a very far or infinity, we have to place a plus 6.5 spherical lenses here so that the image is perceived at infinity. The tubes can be converged, diverged and vertically moved separately or together using the knobs. So they are horizontal, vertical and torsional control. And horizontal, vertical and torsional position of each tube are measured on the scales. They are scales given here. So the amount of vertical deviation or the horizontal deviation or torsional deviation we are doing, we can measure it through a scale and document it. The light control, as I have already talked about, can be used for the cover and uncover test and can be used independently. So the Synapto-4 use three principles. It uses simultaneous perception slides, which can have foveal perception, macular perception and the peripheral perception. As we go towards the periphery, the angle increases, that's why it has the largest perception. And the smallest slides will be preferred, larger for suppression or amblyopia. The other slide is the fusion slide. Mainly in the simultaneously perception slide, if the left eye is given an image of a cage and the right eye is given an image of a bird, both eye is having a normal fusion, they will fuse the image and will see one image that will be bird in the cage. In case of fusion slides, there is a rabbit. One rabbit will have a toy in its hand without a tail, but the other rabbit will not be having a toy but with a tail, and both the image will be fused by the brain and the patient will perceive one image with a toy and a tail. And there is one slide which is the stereopsis slide, in which the stereopsis in both the slides are different, and if a patient is having a normal binocular fusion, they will fuse it and will get a normal stereopsis. So in this condition, a patient is having a right eye esotropia of 20 degree. So this is a ARC. The patient is having pseudophobia. So the image perceived by the right eye will be a white circle and the image perceived by the left eye will be a black dot. There is a harmonious ARC. Image is falling on the pseudophobia. So the brain will fuse to the two images and the patient will see a white circle with a black dot in it. If a patient is having an uncrossed diplopia, means a right eye is seeing a white circle which is not falling on the fovea or the pseudophobia, and the left eye is the normal eye which is not deviated. It is seeing a black dot which is falling at the fovea. The patient will perceive an uncrossed diplopia, means the right eye image will be on the right side, the left eye image will be on the left side. After image test, it's a non-haploscopic test and it stimulates each eye separately. So in this test we use a linear streak of light first vertically and then horizontal, and in this test we have to, when we are using it for one eye, we have to cover the other eye. So if in this eye we are covering the right eye and the left eye we are giving a vertical strobe of light, and in step 2 the left eye is deviated and the right eye horizontal streak of light is shown. So if a patient is having a normal retinal correspondence, so they will fuse the image and a plus image will be seen. But if a patient is having exotropia or esotropia but having a normal retinal correspondence, that time also the patient will see a plus or a cross. But in this test, if a patient is having esotropia and the image is not falling on the fovea or the pseudophobia, in this eye, a patient who is having ESO, the image will fall as an exo. So the right eye image here is falling on the left side and the left eye image is falling on the right side. So this is the only test in which the ESO is perceived as an exo image and the exo is perceived as an ESO image. Here in the right eye, the streak of light is vertical, which will be seen on the left side. In this side, the left eye is horizontal, so it is seen in the left side. In the image D, as we can see, the OD, right eye, the right eye image is perceived as vertical, but the patient is having exo. So here the right eye image will be on the right side and the left eye vertical image will be on the left side. So since patient is exo, but the image perceived is uncrossed. 4 base out test. 4 base out test is a test in which a 4 prism diopter base out prism is placed on one eye. It doesn't depend on which eye it is kept, and there are 2 movements which we have to look for. The first will be a normal fusional convergence and second will be refixation movements. So here we have to look for the refixation moment. If the patient is having a normal response or a normal correspondence and a normal fusion probability, the second moment will be normal. Means if we put a prism in the right eye, the image will move, the eye will move to the right eye, but because of the refixation moment, the left eye again will come back to normal. So monofixation syndrome patient shows normal or versional movement. Some normal patient fail to use fusion, showing version movement but no fusional convergence. Titmus stereo test. It is a vectograph principle. In this, common stereo test is comprised of a polarized vertigraph which is with two plates in booklet form. It consists of three tests: the fly test, the animal test, and a circle test. A polarized glass is given to a patient, and a fly test is used to assess the gross stereopsis, and the animal test and the circle test is used to see the fine stereopsis. If the gross test is affected, we don't have to go on and test for the animal and the circle test. But if the gross test is normal, then we can go ahead and find out the animal test and the circle test. So the fly test, for which is the gross stereopsis, holds a threshold of 3000 seconds. In this, the subject is asked to pick up the fly. If stereopsis is present, the patient will be able to hold the wings of the fly above the plate. But if the stereopsis is affected, the patient will be holding the wings of the fly on the plate. So if the good stereopsis is present, subject identified disparity images of animal among 3 rows. One animal per row is heavily blackened to mislead. The circle test means 9 squares with 4 circles each. One disparately imaged circle per square is present. Subject pushes down the circle that stands out, indicating the stereopsis limit. So the disadvantage is some circles may be selected by the stereo blind observers due to perceived differences, not stereopsis. And it is unreliable in differentiating in patients with amblyopia and heterotropia. So here, if after the animal test and a circle test, we can do the interpretation which is present at the back of the stereopsis test. Here, the circle, if the patient is reading the first circle at the bottom or the right, it will have a 8000 seconds of an arc. And if it is reading since till the last, which is the 9th, then have a 40 seconds of an arc in case of circles. And stereo test animals, if cat can be read, will have 400 seconds. If rabbit can be read, 300 seconds, and if monkey can be read, it can have 100 seconds. Random.e test. In this, 3 cards viewed with is given to the patient, and the patient views it with a polarized glass. The card A will be as a base relief model for a reference, and each stereo figure with a random dot is card B, and a stereo blank with identical background is C. The patient holds the chart 50 cm from the patient, wears the polarized glass, and will have to identify the E, whether it's a pass or a fail. The TNO random dot test. It offers a retinal discrepancies for 15 to 480 seconds of an arc. It is a similar to random dot E test, but provides quantitative response without changing test distance. So here a chart is given which is having a 7 plates with stereogram made of random dots from various shapes. Each plate have figures visible with or without red-green spectacles, assessing stereopsis present. Procedure: first 3 plates establish gross stereopsis, remaining 4 plate quantify stereopsis level. It is available both for adults and children. The Lang test. The Lang test utilizes a random dot stereogram with panographic presentation. Stereopic image of a car, star, and car embedded in a random dots on the test card. Disparate viewing of images achieved through cylindrical lenses on the card surface, eliminating the need of polarized glasses. So there is no polarized glasses required for this test, as we can have seen in TNO test or Titmus fly test. It is available in 2 forms, Lang 1 and Lang 2. In Lang 1, there is basically a cat and a car, and it measures the stereopsis at 550, 600, 120 seconds of an arc. And Lang 2 have a finer measurement which have elephants, clouds, and it measures 200, 400 and 600 seconds of an arc. In this, the patient have to hold the card for 40 centimeter from the subject. Subject asked to name or point a card in front of it. The Frisbee test utilizes plastic cards with 4 squares or small random shapes. Each card contains a hidden circle seen disparately due to displacement of the random shapes. Disparity created by the thickness of the plate eliminate the need of glasses. Here the stereo acuity ranges from 600 to 15 seconds of an arc, and it has both screens for children and infants and adults. Presents in a three-dimensional object field alongside a flat image. The two pencil test. The two pencil test is simple yet effective for assessing the gross stereopsis. It has a threshold value of 3500 seconds of an arc. In this, the examiner holds a pencil vertically in front of the patient, and the patient is asked to touch the upper tip of the pencil with the another pencil using their hand with one swift movement. There shouldn't be different swift movement. It should touch in one swift movement. The patient with stereopsis passed the test with both eyes open. Patient fails the test with one eye closed or when stereopsis is absent, even with both eyes open. These are my references. My basic references are from the Credit Wright, 2nd edition, Pradeep Sharma, 2nd edition, and Von Nuden, 6th edition. Thank you.